And oops, it's already starting. Go back once. So I'm very glad for the title, even though in the beginning I said, oh, yeah, what is remaining? But then on second thought, there's a lot. Because this title is misleading, putting effectiveness up front. And I will try to convince you that although it's important, it's by no means everything we should strive for. So before I have the right to discuss the questions I prepared for you with you, I have to share my conflicts of interest with you. I have, fortunately, a couple of collaborations with different companies, but my biggest conflicts of interest come from the different groups I've been working with over the many years of my career in alphabetic order, and I insist alphabetic order. This is GRAPPA, IPC, and SPIN, and I'll come back to the last one towards the end of my presentation. I'm a little bit biased in that regard because I'm the past president of SPIN, and I want to share a little bit of a concept here with you. Now, this is what I try to cover in the next 25 minutes or 27. Yes, of course, effectiveness is important, but what does it really mean? Then I think everybody has understood that our approach to psoriasis and our perception of psoriasis has changed. We are now talking more and more about psoriatic disease. Still, psoriasis of the skin and psoriatic arthritis remain perhaps the two major domains in that field, and I'll touch upon some of these aspects in that regard. Cardiometabolic complex will be another big issue because this is about live and let die, even in patients who suffer from something that for long has just been regarded as a little bit of a cutaneous inflammation. And then I'll spend just a couple minutes on working on awareness and winning over the next generation. I think this is particularly appropriate today, given the audience. You are the next generation, and it's great to see that you take an interest in psoriasis and perhaps cutaneous inflammation at large. So let's get started. And I think the reason why Peter gave me this title is that we have been living through a period of evolution to avoid the word revolution in terms of efficacy. My predecessor here in Geneva, Jean-Hilaire Seurat, was the first author on that landmark paper that for the first time compared in a head-to-head manner a conventional systemic treatment, namely methotrexate, and one of the early biologics, an anti-TNF, namely adalimumab. And I want to point out that even then they talked about PASI 90, and even if you go to the lower right-hand corner, the PASI 100 responses in 2008. For now, I just want to point out to you that there is, of course, a major gap opening between the biologic and the methotrexate. So that established the superior efficacy of adalimumab over methotrexate in a head-to-head comparator trial. That was just the beginning of a series of direct comparisons. You may know all of these studies, and Chris Griffiths, who will talk later, is the first author on that one that compared an anti-TNF, in that case it was etanercept, to ustekinumab, which came then next. And you see the PASI 90 numbers on the bottom. You see the two doses of ustekinumab, and you do know, of course, that ustekinumab is superior to etanercept at the level of the skin if you look at it head to head, and I think also in a clinical experience this holds true. But that again was just the first or second step. Here's the next one, a direct comparison of an anti-IL-17A inhibitor, secukinumab, direct comparison to ustekinumab, and you see that here again you see that the new mode of action outcompetes the older one. You see that there is a very fast mode of onset and a quite impressive efficacy with regard to the PASI 90 response data. We are at about 80%, so 4 out of 5 patients make it to this already quite ambitious level of response. Well, that's not the end of the story. Here's the comparison of anti-IL-7 and anti-IL-23, in this case, guselkumab to secukinumab. you know this pattern, you know that the IL-23 inhibitors start a little bit slower, but then they catch up. They catch up at least, or in this particular study, they turned out to be superior down the road. And here's the next chapter. With bimekizumab, we now have an IL-17A, IL-17F blocking agent that was compared in a head-to-head trial a couple of years ago to IL-17A inhibition, secukinumab. And here you see that it starts faster and it is more effective compared to secukinumab. And I think that is the basis why Peter gave me that that title. What can we ask more than this? Because we are now having kind of a ceiling effect. You know, the vast majority of patients makes it quite quickly to a PASI 90 or even a PASI 100 response. What can we ask for more? And this is brand new. This is the treatment algorithm in the latest version of the German S3 treatment guideline, which plays kind of ping pong with European guidelines. Every other year, it's either the European group or the German group that updates these, so we try to keep it up to date. You have seen there's a lot of innovation. And the bottom line is that we have a lot of biologics to choose from. Usually, at least across Europe, they can only be used as second line. We try to sneak in a bypass that's hidden in this box here, because we suggest that if it's unlikely that a patient will have a decent response to a conventional treatment, we should consider a biologic treatment in the first place. So we try to make the access to highly effective treatments as simple as possible for the sake of our patients. Now, the end of history, as some said, has come. Some of you may have read that book that came out after the collapse of the Soviet Union. But as you know, history has not ended yet. And I think it is time to not only revisit efficacy, but also other aspects. When I got my title as a board-certified dermatologist, this was 1 year before this New England Journal paper here on the left-hand side. We still learned that we should rotate our patients from treatment to treatment. And on the right-hand side, you see some more modern studies, very typical data sets, and you cannot read this, but that reads week 256. So, you know, these patients are on continuous systemic treatment for 5 years counting and doing well. So I would challenge you and say, well, efficacy is nice, but there's other things that are even nicer. And why can we keep our patients on those drugs? Because all these warnings do not apply anymore. And in my eyes, the single most important advantage of biologics is not efficacy, but it is the lack of cumulative toxicity, which is why we can think about putting our patients on such a drug and keep them on a drug for many, many years, maybe for life if needed. Rheumatologists need to do that because they are dealing with a chronic progressive disease. We are primarily dealing with a chronic recurrent disease. So that, in my eyes, is at least as important, maybe even more important than the impressive efficacy that I have been showing you in the beginning of my talk. Now, here's some food for thought. This is the correlation between clinical efficacy and the happiness of the patient measured by the DLQI. And you know that a DLQI of 0 or 1 means that the patient is very happy, he will love you. But here's my question. If you go to the PASI 100 responders, clear skin, why on earth will 1 in 4 patients still not be happy? That is really a tricky thing. And at the very latest, at this moment in time, we have to ask ourselves, what is it the patients really want from us? And that brings me to the concept of value-based medicine, which some of you may have heard about and hopefully will contribute, if you haven't done so, in the near future. So this is about patient-centered outcomes in the different diseases. And of course, you will find things such as safety, and you will find treatment efficacy. But you see a lot more domains that are relevant for the patients, such as physical activity, social activity, emotional well-being, etc., etc. So we're not talking about one single endpoint, one primary outcome that we will measure in a clinical trial. We talk about many, many aspects that are directly relevant for the patients and have to be addressed and have to be met by the treatments we suggest to them. So that brings me to the idea that psoriasis is maybe more than just plaques on the skin. And nobody showed it better in my eyes than Uli Mowitz from Kiel with his psoriatic spheres. I mean, we all learned that it is a priori a skin disease with a genetic predisposition, environmental triggers. But for quite some time, we appreciate now that it's not just local inflammation, but it's a systemic inflammatory condition, which is associated and may even drive cardiovascular comorbidity, may have an impact on psychological diseases. There is this concept of depression being a chronic inflammatory disease as well. And then there is the next level, so to speak, quality of life, burden of disease, etc. So all of this has to be on our radar when we try to manage our patients correctly. Now, for, I think, 12 to 15 years, I've always started my talks on psoriasis and the pathogenesis and the management with these 3 slides. So first I started showing all the different clinical manifestations, and then I would say that this is just the tip of the iceberg. The best way of showing that is these beautiful PET CTs that cardiologists such as Nihal Mehta from NIH showed, that makes the point that inflammation is not only there at the level of the skin, so everything that's marked D is the psoriatic plaque, and on the joints, that's A, but it's also at the level of the liver, as you can see, and other organs, including, and that's particularly important, the vessels. So a patient with psoriasis also has inflammation on many, many other sides of the body, including his blood vessels, and that explains the increased cardiovascular risk of those patients that has been documented as long ago as almost 20 years. That is, of course, of major importance for the patients. So to put all of this together, we should not only just look at the skin, but we should look at the associated comorbidities that we usually find. And these 2 tables may be a little bit difficult to read, but when we translate this into our clinical decision making, and that is my point with this slide here, is we need to be aware of the comorbidities of the patient. So here on the left-hand side, you see them all lined up, starting with chronic inflammatory bowel disease. And in the top part of the table, you have the conventional systemic treatments. In the lower part, you have the biologics. And if you have somebody with moderate to severe psoriasis of the skin and chronic inflammatory bowel disease, you know that if you were to choose a conventional systemic, and maybe acitretin or methotrexate, and not so much fumarates or cyclosporin, whereas if you go to the biologics, would be a good idea to go with an anti-TNF, with the exception of etanercept, because that's a fusion protein, doesn't work in these diseases. Or you prefer perhaps the IL-23 inhibitors, which are already approved also for this indication, and you rather would not go with an IL-17 inhibitor. So that to say that for our clinical decision making, we have to be aware of the whole picture of all these comorbidities in our patients to make the right choice. Now, let's go to some more clinical aspects like individualization of therapy. And you may imagine now with this mounting pressure of ever improving efficacy, every new product coming along had to show superiority. Otherwise, the management would say, we don't have a product for the market in psoriasis. So one may well think that the dosing regimen in these phase 3 trials, which then became the basis of the label of the drug, they're quite aggressive, and maybe we overtreat most of our patients. And that is why more than 60 experts from around the world, and I'm sure several of you have contributed to this exercise, were asked on how we can address this issue. And there's now some guiding on how to reduce the dose of biologics. Also in part because we can save some money, but also because we honestly think that we overtreat quite a number of our patients for the reasons just discussed with you. So don't be misled. Don't think that the label is the optimal dose for all of your patients. Ask yourself, is this the right dose for that patient I'm currently facing in my office now? Now, the big question, of course, if we can control the signs and symptoms so well, can we perhaps modify the disease down the road? And I think that has been on the agenda for a couple of years now. And I just want to revisit briefly two initiatives in that regard. On the left-hand side, you see the concept of the group around Lars Iversen, the STEP-IN consortium that asked the question, what if we hit hard and early with an IL-17A inhibitor and they use secukinumab, reasoning that IL-17A is perhaps the single most important effector cytokine in the inflammatory cycle of psoriasis. And if you want, the competing consortium is the GUIDE consortium, about a couple of Germans like Kilian Eirich and Knut Schäkel, who said, well, what if we used an anti-IL-23 such as guselkumab, reasoning that with that we may perhaps reduce the number of resident memory T cells and maintain or even increase the number of regulatory T cells in the skin, well, that they should be capable of controlling the chronic inflammation. So that is the two concepts that have been put to a test. This is the corresponding protocols. So the STEP-IN asked for an early treatment with the secukinumab, and they compared it with phototherapy, and then 1 year down the treatment they stopped and followed up on the patient and asked the question, did we modify anything? And the GUIDE protocol stratified the patient, and they introduced the term they called super responders. The super responders are people who have a clear skin both at week 20 and 28 into the treatment. Those of you who do clinical studies know that there's a little bit undulation of the PASI, and sometimes they have a clear skin, the next day they have just a little plaque here or there. So that would disqualify these patients from being super responders. So what did they see? Some of the data are published by now. So first of all, the results at the end of what I would call still more or less the induction phase. So on the left-hand side, you see very impressive PASI 90 responses with secukinumab. You see some less effective efficacy amongst the patient with the phototherapy. And I'll show you the follow-up data in a moment because they are perhaps even more relevant. On the right-hand side, you see the number of super responders is 1/3. But if you split them, and that's the interesting part of that study, and ask, what about those whom we catch early in the disease career? So they what they call short disease duration, SDD, less than a maximum of 2 years, versus long disease, more than 2 years. You see that those with short disease respond better to guselkumab than those with a longer disease duration. So also directing us to the idea of hitting hard and early. But does this modify the treatment rather than increase the likelihood to get a PASI 90 at the end of the induction? So I think the GUIDE data are not yet published, but some of the STEP-IN data are. And this is from this year's paper with Lars Iversen. So you see that after 1 year, they stopped secukinumab. They followed up the patients. And if you look at what happened within the second year without any treatment, you see that a third percentage of patients has a very low PASI or even basically clear skin. And if you take the definition of rheumatologist that says that if you have no symptoms and you have no treatment, that's called remission. Here you have a remission rate of about 10 to 12% of patients 1 year after stopping secukinumab. So I would call it remission. Is this true disease modification? We can discuss this. It's a question of definitions, but I think definitions have to be clear and accepted by everybody to have a meaningful and enlightening discussion. For me, this is remission in a portion of patients, but we can discuss this later. Now, we take it for granted that we know what psoriasis is, but do we know this? And I just want to throw one slide at you that comes from our twin university in Lausanne, the second university in the French-speaking part of Switzerland. So that is data from Michel Gier's group, and you know that he looked at transcriptomic data for quite some time, and you can use this to actually establish the diagnosis in clinically unclear cases. So just show the typical question: is an erythrodermic patient suffering from psoriasis or atopic dermatitis or perhaps lymphoma? You have to look at the upper left-hand corner, and then you see the Th17 signature, and then say, this is psoriasis, I'll treat that patient for psoriasis. There's a lot of other scenarios where this transcriptomic analysis can be used for establishing the right diagnosis and then putting to work the right treatment. So maybe a couple of years down the road, we will start to forget about these hundreds and hundreds of entities that are described in textbooks. And we will just ask the question, which pathway is activated and which targeted therapy do I need to really block that? That is good and bad. We can discuss this afterwards as well, if you wish. Now, even if we think that we know everything about pathogenesis, I just want to throw a little bit of data at you that shows you that there is still room to come across very exciting new things. I think we are somewhat overwhelmed by all the immunology that we were taught in the last years, and that of course reflects the modes of action of the treatments available. But here's a piece of data that I have to admit, this is from my lab. So Su-Wei Zhang is a very talented PhD student. She did that with Maria Shutova, a cell biologist from Russia. And they showed that actually mechanotransduction is intimately linked to inflammation at large. And they showed it in the example of psoriasis. This can, for example, in part explain the Koebner phenomenon, why mechanical stress induces inflammation. And the bottom line is, this is the graphical abstract, that adhesion molecules and the cytoskeleton play a key role in activating TGF-beta, and that has an impact on epithelial biology and may drive inflammation. So just to tell you, if you look around and if you don't want to stop at the level of T-cell immunology, there's so much more to be detected, unraveled, and investigated, even at the level of the pathophysiology of psoriasis. Now, I always took a huge interest in psoriatic arthritis, and I have to talk a little bit about psoriatic arthritis here. And I do it a little bit linked to the idea of disease modification, because we know that in most patients, psoriasis patients will eventually develop psoriatic arthritis. And this transition puts us in the unique position to try and prevent the onset of psoriatic arthritis. So where are we with regard to this? Before I answer this question, I want to underline the importance of psoriatic arthritis in its own right. Because if you look at these hands, of course, you can say, I can treat that topically. You can even topically, quote unquote, treat nail involvement, but you cannot treat arthritis topically or by phototherapy. This is why this particular comorbidity is so important, because even mild psoriasis in association with joint involvement needs systemic therapy. And of course, there is recommendations on how to treat that. Most of these recommendations follow the initial concept of GRAPPA, suggesting that we should address this disease domain by domain. Of course, this is very rheumatology lopsided, because psoriasis and nail of the skin and nail psoriasis are just two little domains here, side by side with a lot of rheumatology domains. But just to make the point that it becomes quite complex, and psoriatic arthritis is a very clinically diverse disease if you want to treat it right. This is a piece of evidence that tells me that GRAPPA actually so far has failed and still has to do what it set out to do, and that is to treat psoriatic arthritis correctly. And that is a study that asks the question whether it makes a difference whether the patient is first seen by a rheumatologist or dermatologist. The bottom line is on the lower right-hand side here. So although the diagnosis is usually established relatively quickly. I say relatively because a few weeks or months you can discuss, this is still relevant, but the big message is here. You see that there is a 2 at the dermatologist side and a 0 at the rheumatologist side. That is the time between establishing the diagnosis of psoriatic arthritis and initiating an adequate treatment. So at least a conventional disease-modifying antirheumatic drug, something such as methotrexate. And this is not weeks and it is not months, it is years. And so I have to say, look at this has been published in 2020. So despite, I don't know, 15 years of efforts by Grappa, there's still a delay of 2 years amongst dermatologists until they finally decide to put the patient on an effective treatment. And that is bad news because psoriatic arthritis is chronic progressive and many patients within 2 years will develop joint damage. So this is unacceptable, and Grappa has to find a way to drill home this message, and maybe IBC has to pick it up and say, listen, yeah, we are dermatologists, but we are smart people. We can ask the question whether the joints hurt, and we can see whether the joints are swollen. This still remains a major issue for a clinical dermatologist interested in psoriatic disease. But here's what I really wanted to talk to you about, and that is the question, can we prevent it? So this is a nice paper put together by Alice Gottlieb and Joe Merola. Both are dermatologists and rheumatologists, and they put together all the risk factors that we see in patients who have a high likelihood to develop psoriatic arthritis eventually. If you miss that, at the next level, we will have imaging abnormalities, and finally we have symptoms, and that is then established psoriatic arthritis. So the idea is to really thoroughly screen patients who are at risk to develop psoriatic arthritis, and then try to treat them early and perhaps at least delay the onset of psoriatic arthritis. And that has been shown. So here's data from Paolo Gisondi, where he compares the delay of psoriatic arthritis in a cohort treated by phototherapy versus targeted therapy. And you see there is a gap. And that is good news because it says that the targeted therapies, so a priori biologics, they can delay the onset of psoriatic arthritis. And many of you may have seen this publication because it claims that there is even a difference between the modes of action that you can use, in as much as the IL-23 inhibitors may be the most effective ones when it comes to delaying psoriatic arthritis. That made a lot of noise. On the left-hand side, you see the editorial that was published alongside that paper. I think there's a lot of questions to be asked because this is a retrospective analysis, and I'll be happy to discuss this with you during the Q&A session. I'm not convinced that IL-23 inhibition is really superior to TNF-alpha inhibition when it comes to preventing or delaying the onset of psoriatic arthritis. To be discussed if you're interested. Now, towards the end of my talk, the cardiometabolic complex, the question of live or let die. My group was very, very active in that. Many other people took an interest after epidemiologically it has been shown that psoriasis is an independent cardiovascular risk factor. The left-hand side, you see atherosclerosis at the level of the coronary artery. In patients with psoriasis, we did a study on that and showed that among psoriasis patients, this is a phenomenon that's quite frequent compared to non-psoriatic controls. And together with a lot of other data, we put together what we call a psoriatic march. If you look at this scheme on the right-hand side, this story has been told by the diabetologists for many, many years. And we try to convince people that's also true for psoriasis, starting with it being a systemic inflammatory condition. It leads to insulin resistance. These receptors are also present on endothelial cells. And if there is resistance, there is endothelial dysfunction, which makes the vessels stiff and finally atherosclerotic. And we did a study that's not a body count, but we looked at vascular elasticity directly. So we put a sensor into an artery and we measured elasticity before, that's the red, and after a successful treatment, that's the blue lines, of psoriasis, and we showed that we actually can reestablish a better elasticity on the vessels. We did that with fumaric acid esters. On the right-hand side, 1 year later, you see the data from a cardiologist group who used adalimumab, so an anti-TNF, to show the same thing on the top side. here on top you see the improvement of elasticity, and that is, according to many cardiologists, the next best thing if you don't want to measure mortality 10 years down the road amongst 10,000 patients, to indicate where you are with regard to an individual cardiovascular risk. Now, this has been reproduced on a much larger scale. Here you see a very famous New England Journal paper, the famous Cantor study, that showed that if you treat patients for many, many years with a systemic anti-inflammatory drug, this is with an anti-IL-1 beta, patients who have a high risk to develop a myocardial infarction after they had a first myocardial infarction, you can lower the risk. If you look at the curves, it's hard to show, it's hard to see. The effect size doesn't seem to be enormous, but it made a lot of buzz in the press. So here's some Novartis communication on that study. But the effect size was such that in the end, of course, it didn't make it to the daily practice. Other interventions did, like statins, and now we are talking about the Together studies. We can discuss this at the end if you wish. And of course, if you think that this is yesterday's news, I think many of you have read or came across the Together data. That's Lilly's initiative. They asked whether the combination of an anti-IL-17, ixekizumab, and an GLP-1 agonist, tirzepatide, would be synergistic already to better treat psoriasis, given that this is a chronic inflammatory condition with insulin resistance, but also with regard to the metabolic aspects and the overall well-being of the patients. And this is about to be published now. There's the Together PSO and there's Together psoriatic arthritis trials that are bit by bit published by now. So it's not yesterday news. And to the end, there is a lot of publications on psoriasis, but I think that awareness remains a big point we need to address over and over again. Peter, you remember May 2014 when you were here in Geneva and both of us went to the WHO, because that was the first time when the WHO actually issued a declaration on psoriasis, saying that it is a global challenge. There's a lack of awareness. There's a lack of access to sufficient treatment. And I think this will echo in Chris Griffiths' talk after mine. And I'm very glad to see that the skin remains on the radar of the WHO. This is from last year, where the WHO again addressed skin and say, well, cutaneous disease is actually big. You know, you have to address the needs of the patients with skin diseases, not just with inflammatory infectious diseases or cancer. That is good news, but there's a long way to go. And to wrap up, I hope I didn't surpass my 30 minutes. I'm very happy that I had the privilege to be part of and have the privilege to be part of all these three networks, because there is a common denominator. First, I honestly think that they are not exclusive. You can be a member of GRAPPA and be excited and proud of being a member of IPC as well as SPIN. The common denominator is a psoriatic disease. We have to build excitement amongst the next generation to ensure that we will see continuous progress as we have seen in the last 2 decades. And I will just take this Congress as an example. And of course, I'm biased because I was the president back then, so it was up to me to organize this. SPIN used to be PIN, Psoriasis International Network. Basically, it's the psoriasis task force of the EADD. And we said, well, although there's still unmet medical needs, and I discussed about this, so much more unmet medical needs with regard to many other chronic inflammatory conditions of the skin. And that is why Jo Lambert, who is actually the speaker of the psoriasis task force of the EADV, said we should broaden horizon, talk about skin inflammation and psoriasis international network, so that the companies whose money we use every once in a while to do research, take an interest in all the other diseases. And for now, back then we covered psoriasis, alopecia areata, hidradenitis, vitiligo, and atopic dermatitis. And we try to broaden the spectrum. But what I really wanted to say is not that this was a wonderful location and outside and in, but that it attracted many, many young people. So the size was about right. We were 800 delegates. This is a nice size, I think, because it still allows to interact. You see that posters, I love posters. Posters have to be physically presented, and they are where the companies are, they are where the coffee break is, they are where the people are. And we organized poster walks because this is a wonderful format to interact with the lead authors of the posters. This is where you get a meaningful feedback. It's not just your 2 minutes, one question on the occasion of an oral presentation. There you can really interact, ask your questions, start networking, and of course we gave prizes to the best posters. So if you think that the end of history has come, I think that's actually not quite true, and maybe the end of history has come. With all the young, talented people on the call today, I'm very optimistic with regard to the future. And so if somebody tells you that the sky is the limit, don't believe it. There may be something beyond the sky, as you see on this image from medieval times. And with that, I thank you very much for your attention. And